Welcome to Talking Health. I'm Trudy Lieberman, contributing editor to the Columbia Journalism Review. This is the launch of Talking Health on CUNY TV, channel 75 here in New York City. Healthcare costs continue to rise in this country. Today we will be discussing how the new health reform law affects people in their pocketbooks, especially during this recession. A study out in December from the Kaiser Family Foundation found that 1 in 4 households had trouble paying their medical bills last year. A little over half said they delayed getting care because of costs. Our guests are Katherine Swartz, Professor of Health Policy and Economics at the Harvard School of Public Health, and Stephen Rosenthal, President of CMO, the Care Management Company, a subsidiary of Montefiore Medical Center in the Bronx. Later in the broadcast, we will be joined by T.R. Reid from Denver via Skype. T.R. Reid, a former reporter for the Washington Post, is the author of the best-selling book, The Healing of America. Welcome to all of you. We've heard a lot about what health reform does to provide insurance to people who are now uninsured, but we've heard little about what it does for people who already have coverage. Kathy, can you tell us a little bit about how health reform will help these people?
I think there are two parts to this answer. First is that people who currently have health insurance are paying a lot already for people who do not have health insurance. They're paying more in property taxes, income taxes, sales taxes, a variety of other sort of hidden pieces, particularly if they themselves end up in the hospital, they will pay more for their health care there, all to help pay for the care of people who do not have health insurance now when they seek care. So by having health insurance, the people who don't have it right now, they are going to be themselves paying more for their own care and therefore keeping the costs lower for people who currently have health insurance. But the second reason, and I think it's an important one that is somehow being lost in the debate, is that people who currently have health insurance worry a lot that they may lose their health insurance, especially with this recession. Many people have their health insurance, as you know, tied to where they work, and if they're worried about whether their job will still be there next month and that they could lose their health insurance, this law makes it clear that you are going to have access to health insurance regardless of whether you have it through an employer, as you do now, or whether you have to purchase it on your own. It makes it much more feasible to buy it on your own.
Do we know how many people have lost their coverage during the recession and what that's done to increase the number of uninsured?
It's a really good question. I don't think we know the exact number, but we know from the increase in the number of people without health insurance between 2008 and 2009 that it went up about 5 million at a point in time. And that gives you at least one estimate. It's probably a lower bound in the sense that there are people who have no doubt given up buying their own coverage. Say they may be self-employed or working on contract basis, and I've decided not to keep buying health insurance. So I think somewhere at least 5 million at a point in time.
We often talk about health reform as being very beneficial to people who have chronic illnesses, that they're now going to get covered and so on. Can you talk a little bit about what specifically that will do to improve the quality of care that they do get?
I think that people who have chronic illnesses worry all the time that they may either exceed a limit. They may have this annual limit, which is now going to go away, on the amount of dollars that can be spent on them for their care. Especially if you have any kind of expensive chronic condition, you could be well over $100,000 in a year. So for many people, they are going to benefit because this limit will be gone by 2014.
Recently, I spoke with a young widow in Queens. Etoile Edwards is a 34-year-old woman who suffers from a serious health condition. She does not produce enough red blood cells.
I get infections really easily, and with the problems with my clotting factors causes blood clots, which leads to dying off of bone, certain organs lose oxygen, and they become paralyzed.
Her condition, diagnosed when she was 18, frequently requires hospitalization. A mother of a 9-year-old, she's had both hips replaced.
Now I'm happy that I had it done because I had no quality of life. I couldn't go out and run in the park with my son or take walks.
She had health insurance through her husband's job as a hospital respiratory therapist, but she lost it when her husband died unexpectedly 2 years ago. She now has coverage through her job at a daycare center.
It's really basic. It pays for doctor's visits, certain hospitalizations, and x-rays and blood work. Outside of that, it's at the discretion of the insurance company whether or not they're going to cover or pay for certain tests or procedures.
It doesn't cover a machine that helps her breathe at night.
I put it on at night and it helps me breathe. It helps my body blow off the carbon dioxide. Basically, I don't die in my sleep.
That costs $250 a month to rent. Nor does it cover the nutritional supplements that add another $245 to her monthly medical bills. For a while, she got help from Medicaid, but her son's Social Security survivor's benefits made her ineligible for other government help.
He gets $1,107 a month in benefits, and that check put me over the limit and made me ineligible to continue getting the Medicaid. And my monthly take home from my job comes to be about $2,000 a month.
The costs for her prescriptions run about $1,400 per month. They are covered by her union welfare benefit fund. However, she cannot claim more than $5,000 for the entire year.
Unfortunately, because of the cost of my medications, that $5,000 cap is done, this year it was done in March of 2010, I was done. And from that point until December 31st, 2010, I'm responsible for those drug costs. At one point, the cap was $10,000. But I believe it was a couple of years ago, they dropped it down to $5,000.
So as far as you know, the cap will continue?
The cap will continue, yes.
After Edwards has reached the cap, she spends more than 1/3 of her $37,000 income on prescriptions. The new health reform law prohibits insurance companies from setting annual caps on essential benefits. That means, in theory, Edwards would no longer have her drug expenses capped. Her insurance would pay more of the cost for her medications. However, 222 health plans and employers have already gotten exemptions from the law. That means caps for their workers will stay in place at least through 2011. So far, Edwards' Welfare Benefit Fund that provides her drug coverage has not asked for an exemption. A lawyer for the fund says it's premature to discuss what they are going to do. Kathy, those exemptions seem to deprive some people of the help that the new law was supposed to give them. Can you explain a little bit about why these companies and benefit plans are coming in asking for these exemptions that are going to keep the caps in place for people a little bit longer? Can you explain a little bit more about that and then tell us when you think all this is going to end and what the law says about it ending?
So this is a good question. I view this request for the extensions for another year as part of the implementation process. This is an enormously complex law, and even though we're rolling it out through the end of 2013, so it takes effect January 1, 2014, this is an enormous job to get everything in place. So these companies that have come in asking for an extension of 1 year, I think the administration granted that just to allow for more time to work this through. So the quick answer to your question is they will be gone by 2014 for sure. My own hope is that they will be gone by 2012. These mini-med policies are not very good policies. I think that the young woman you've just described is a very good example of where this is not full health insurance in the spirit of the new healthcare law.
Well, specifically, how will having more people covered after 2014 when the law takes full effect, how will this benefit your hospital?
Well, we'll probably receive slightly more income as a result of no longer having the bad debt and charity pools. So those dollars, which typically may have ranged in the area of 10 to 20 cents on the dollar, the likelihood is that the institutions, all healthcare institutions, will receive more dollars associated with that. The challenge often is that in your communities where you're largely government programs like the Bronx, those dollars are not quite the same as in the private insurance market.
Stephen, let's talk a little bit about hospital costs. We know that hospitals are large drivers of the increase in costs in the healthcare system, accounting for about 1/3 of the nation's healthcare bill. What exactly is causing these premiums or these hospital costs to rise, which are then filtered into the premiums that we all pay?
Well, hospitals, as you can imagine, have very high fixed costs, and the majority of the costs tend to revolve around staffing. So hospitals have physicians, nurses, all of which compensations continue to rise at reasonable levels. And then we're dealing with the same challenges that many other industries are dealing with. Our supplies are escalating at rates higher than inflation, perhaps particularly drug costs. Many new drugs have been introduced where hospitals are required to provide those services, changes in technology. And as an academic medical center, you're often forced to have the most recent technology available, and those costs continue to rise. So the burden in providing some of the services that are available today are associated with increased costs.
Other countries manage to provide health care to all their citizens and spend less than we do. To talk about how they do that is T.R. Reid, joining us from Denver. How do other countries actually cover everyone at lower cost?
Well, the most important thing is they don't all do it the same way. It's not all socialized medicine, as a lot of Americans seem to think. Some countries do it through government. Government owns the hospitals and government employs the doctors and pays the bills. That would be Britain, Spain, Italy, Scandinavia. I'd call that socialized medicine. But a lot of countries, Germany, Switzerland, Belgium, Netherlands, France to a degree, Japan, cover everybody with private docs, private hospitals, and private insurance. It's universal coverage, but it's definitely not socialized medicine. And then some countries have kind of a marriage of the two. This is the Canadian model. Private doctors, private hospitals, but a government-run insurance scheme in Canada. That's called Medicare, and we copied it when we gave health insurance to our seniors. Our Medicare system is basically the Canadian model.
The law has provisions designed to help small businesses. These firms have a tough time covering their workers. Over the last few years, many of the smallest businesses have dropped their coverage when the premiums became unaffordable. Many small businesses that continue to cover their workers now give them fewer benefits. I spoke with a small business owner in Brooklyn who now pays the entire premium for the workers he insures.
Hello, good morning, everybody. Good morning. What's going on?
Peter Patino owns Active Transport, a messenger and shipping service. He employs 15 workers. Like other small businesses, he's had to cut his workforce during the recession. Because it's a competitive business and profit margins are slim, he can't afford to give them all health insurance. The monthly premiums for the 2 workers he does cover comes to about $260. Premiums have risen 13% for 2011.
I'm going to try to cover their increase.
The new law makes it possible for small businesses to get a tax credit to buy coverage. The credit will cover 35% of the employer's share of the premium, but only if the business employs fewer than 25 workers whose average wages are below $50,000. In 2014, the credit will cover 50% of the premium.
No, not going to get the money up front. No, there's no way to get the money. There's nothing stating in the new bill that says that businesses will be getting any money up front.
He has 20 years to use the credit.
It is a credit by which I can only take if I make a profit.
The tax credits are supposed to help with the premium increases. Small businesses have seen their premiums increase about 4.5% this year on average. Large businesses have had even larger increases. Some insurance companies say that's because of the health reform law. Kathy, are the new benefits required by the law, such as eliminating the annual caps and providing the tax credits for small businesses, really the reasons behind these big premium increases that we're seeing this year?
I personally believe that this larger increase that has come about in this last year is really essentially of insurance companies looking forward and trying to start from a higher base for their premiums. There's no way that these annual limits or lifetime limits coming off have caused these very large jumps in the premiums that we're seeing. I would also say, in response to the tax credit for small employers, that this issue is one, again, where the 3 years needed to implement this law, I would expect some changes to take place. In the same way that individuals who will get subsidies will get advances on their subsidies so that they will go during the calendar year to the insurance company they choose, I would expect the same thing to eventually happen with the tax credits for small employers, that those won't be credits that can only be used if you make a profit. So this is all being worked through.
You expect that to change?
I do.
One thing that I keep hearing from insurance companies, and that's that they now have to cover children, all children, and if those children have serious diseases such as cancer or cystic fibrosis, this really adds a lot of claims costs. And so many of them are saying that now all of this is piling on, and now they have no more annual caps, so people have a lot more costs that are being shoved onto the insurance companies. That has no bearing in the premiums that we're seeing?
I don't think so. I think it's really important to remember that half of the population accounts for about 3% of all of our healthcare spending. And children in particular are very healthy as a group. So there are going to be some sick children. Some of them, if they are very sick, are covered now by Medicaid. They're already out of the private insurance companies' systems. One reason that we have the requirement that everybody has to have a shared responsibility here and that they have to have health insurance for themselves and their children is just for this purpose, to make sure that people are covered by health insurance when their children are healthy, when they themselves are healthy, and not that they roll in and apply for health insurance as soon as they find out that their child has a very serious illness. That's why we want this requirement in place. But I do not believe that the idea that somehow there are going to be an enormous number of sick children suddenly being covered is what's driving up these premiums. No.
Let's go back a second to Mr. Patino and the rate increases that he's been getting. How do the rising costs that you experienced in your hospital feed into the premiums that he's seeing?
Well, they're probably directly related to the insurance company's cost of reimbursement, and so they're passing those costs on as well. But it's never, and I agree with the statements that were just made, it's not clear to me that they're directly related to their experience around the increased costs. I think it's their anticipation of changes in the future around their requirements at being at a certain level of expense. So I think there isn't as much correlation as we would like there to be, and perhaps an opportunity for us to change that as we go forward.
What if hospitals became a little bit less competitive in the area of the very high-tech new technology where everybody wants to have the latest and greatest?
Well, I think competition often changes those things, and I think you're absolutely right. Very often there are more MRIs in a particular community than there are necessarily even services available to access them, and the technology often drives that. I think as long as we're dealing with a fee-for-service, transaction-based business where there's a disconnect between the continuity of care of an individual and the transaction, we'll continue to see growth in areas where individuals can attract those kinds of fee-for-service transactions. Under healthcare reform, as we begin to look at bundling payments and looking at managing within a budget, I think you begin to see some of those opportunities disappearing.
Most people these days are familiar with the managed care HMO concept that has been around now for over 20 years or so. And they've also known about bundled payments, which were called capitation payments. How is this new form of bundled payments different from what we had when managed care became very prominent in the early 90s?
It's a great question. I get that question, and I hear that question frequently. I think we know a lot more today. When this first began in the 90s, it was largely all based on price, all based on cost. And I think the challenge then was to lower cost, and there wasn't the information available, and there wasn't the knowledge around managing the continuity of care around specific diseases as there are today. Plus, there's the technology in the clinical information tools that are more available today, and part of the healthcare reform is actually funding the more rapid implementation of clinical information tools for providers around the country. So with that information and with a clear understanding of what the goals and objectives are, I think we can be much more successful today than we were back then.
Kathy, what kind of cost containment has been built into the new law?
There isn't very much, actually. I think that Congress left that for a later day, just as in Massachusetts. We passed our health reform law to increase access, and then a second law to try and slow the growth in healthcare costs. And I think the strategy, which I agree with, is one of get everybody under the tent, and then you can go forward, and it's a lot easier to, as Steve says, talk about ways that actually will allow all kinds of healthcare providers, hospitals, physician groups, accountable care organizations to be more efficient about delivering quality care. But I don't think you can do that unless everybody in the country is basically on the boat.
Tom, you heard Kathy say that cost control probably was not the major point of health reform this year. And I've heard you speak about this also. What do you think is going to happen since we don't really have a lot of really strong cost control measures?
Trudy, there is cost control in this bill. It's called the IPAB. This is the Independent Payment Advisory Board. Doctors are scared to death because this organization will have the power to set the prices for thousands and thousands of medical procedures.
There's been talk, actually, of that provision being repealed at some point. Do you think that could happen?
Yeah, I think the doctors, hospitals are very powerful lobbying groups in America, and they hate IPAB. They hate the idea that somebody's going to try to control costs. So they'll fight to repeal it. On the other hand, the insurance companies want to keep their costs down. And presumably anybody who's worried about our federal deficit should want to keep healthcare costs down. So my guess is the IPAB is probably safe of all the pieces of the 2010 Reform Act that you might want to repeal. Why would you repeal the one that's going to control costs? I don't see the advantage there.
How will those cost containment measures, such as they do exist, actually affect your bottom line?
Well, I think immediately what happens is all institutions will see their revenue fall as utilization changes as well, as we're experiencing currently. I think many institutions' bottom lines will continue to erode, particularly those of us who are dealing with more government program payers, where those budgets we know are being reduced over the next several years. So I think, unfortunately, we'll begin to see much more challenges in the healthcare market as it relates to employment over the next several years.
What are other countries willing to do that America is not?
Well, in the first place, they all made the commitment to cover everybody, and that's fundamentally a moral decision. All the other rich countries said, doggone it, we're a rich country. Anybody in our country who's sick should have care, and that we've never, as your previous guest said, we've just never made that commitment here. Covering everybody saves money. All the other countries prove that. And also, if everybody's in the system has more clout to control the costs of providers, of drug companies, of hospital companies, of doctors. If everybody's in, then you have a buyer's market to say, here's what we think the prices ought to be. And that's one of the reasons all the other countries have vastly lower prices for the same procedures.
What are other major differences between our health system, as it will be under the new law, and those of other countries?
Well, again, the fundamental difference is even under the new law in 2019, 23 to 25 million Americans won't have health insurance. These are still people who are going to rely on going to the emergency room when they get too sick. No other country would arrange things that way. It's cruel. It makes people live with pain, and it just costs a lot more. In other countries, as I said, there are these central price controls, and you know what, Trudy? They drive innovation. This notion that we have to pay through the nose for everything because that pays for research, I don't buy it. We have great medical research in America. There's no doubt about it. Our innovations are world leading. But guess what? Other countries with much lower cost structures are also very innovative. Anybody watching the show who's walking around on an artificial knee or an artificial hip, that's French technology. Anybody who's seen her baby in the womb through ultrasound, that's Swedish technology. The most commonly, the best-selling drugs in America, these statins for cholesterol control, most of them have been licensed from Japanese companies. So those countries keep down, they have central control over prices, and guess what? They still have really good innovation. So I think this is a fundamental point for Americans to realize we could pay a lot less and still have great medical innovation. The other countries prove it.
Thank you for being with us. Our guests have been Kathy Swartz of the Harvard School of Public Health, Stephen Rosenthal of Montefiore Medical Center, and journalist T.R. Reid. Watch for other Talking Health shows later this year. Thank you for joining us. I'm Trudy Lieberman.
This broadcast has been brought to you through a grant from the Commonwealth Fund.